Hello and welcome back. In this lecture, we'll be continuing our conversation about epidemiology and how it works. Now, in the first lecture, we talked a little bit about the distribution of diseases in the population, a little bit about group associations, where we see that diseases are sometimes associated with different populations or certain regions. And this can be really helpful for forming hypotheses about what's going on with the disease. In this lecture, we're going to be focusing more on trying to understand what a disease is caused by. And then secondly, once you know that, how can you actually prevent that disease from occurring? So let's start off thinking a little bit about identifying causal factors related to public health concern. So when we think about causation, very often the public has this very simple view of it, where one thing absolutely causes another thing in all circumstances. And that is often referred to as the idea of a factor being both necessary and sufficient to cause something. So what does necessary and sufficient mean? Well, necessary means that if that factor is not present, then you would never have that disease. So the example here would be if people aren't exposed to lead, then people would never have cognitive impairment as a result, right? Being sufficient is the opposite idea. So the idea here is that if someone is exposed to lead, they will always have cognitive impairment. So what these ideas are actually a fairly high standard for most health related concerns. The truth is that very often most diseases are caused by multiple different factors, and so you might have no lead present, but so you might still get cognitive impairment for other reasons, for example. And in terms of sufficiency, well, it might be the case that in certain circumstances, someone could be exposed to a risk factor and never actually develop the health impacts that are expected from it. So the truth is, in public health considerations, very often these simplistic views of causation, where it's very all or nothing type approaches, actually aren't how we typically think about causation. Instead, we think about contributed causes. So things that are factors that are associated with a disease, but may not always be present at all times, or wherein there might be other factors which may result in that disease as well. So there was a criteria that were developed to try and describe, okay, if we're going to think about a complex disease, how are we going to think about identifying factors that are contributing causes? Well, Sir Bradford Hill put together a set of criteria, which is essentially the same criteria that we're still using today. So the first criteria is that the cause is associated with the effect at an individual level. All right. So this factor that we think might be causing a disease, we can see that people who are exposed to it or not exposed to it actually go on to develop that disease or not. We also would want to know whether or not the cause actually precedes the effect in time, right? So if someone develops cognitive impairment and then they're exposed to lead afterwards, well, that doesn't suggest that the lead is actually causing the cognitive impairment, does it? Right? So we want to make sure that the exposures are occurring before someone gets a disease. What we also want to know is whether or not if you change the amount of cause or the amount of exposure to something, that will alter the effect. Okay. So that's a really important thing, because if you can take something or give it in a controlled experimental way, that's really strong evidence that that thing is actually causing that condition. You also would want to think about things like strength of the relationship. Now, having a stronger or weaker relationship doesn't always show that something is a cause or effect, but it does lead to a stronger belief that this might actually be causing something. So if you have a very strong effect, a very weak effect in terms of the relationship between a risk factor and a disease, well, that might be due to confounding or due to some other artifact in the study, right? Whereas if you see a very clear, very strong impact, well, that's suggesting that something really is going on and that it really might be that risk factor. The other thing that we look at are things called dose responses. So the idea here is the more that you have of an exposure, the more severe or the more likely someone is to develop a disease. Consistency is the idea that that exposures lead to disease across different situations, different environments, different countries. So if you increase trans fats in Japan, you will have similar impacts on heart attacks that you see if you increase trans fats here in the United States, right? So that it's sort of a consistent effect that we're generally seeing. And then biological plausibility. Again, we can show that there's relationships between risk factors and diseases without necessarily understanding all of the biological pathways. But if we do understand the biological pathways and it sort of makes sense that something's going on there, that increases our confidence that what we're seeing is an actual effect going on. So all these different ways of showing that a disease, that a factor is more likely to be contributing cause to a disease, can be addressed using different types of studies. So in epidemiology, they design all sorts of different types of research approaches to try and answer these different questions. And different approaches will be useful for answering different types of questions for these criteria. Now, when you've done enough of these studies that address these different components to those 7 criteria, we increasingly will become confident that we can describe something as being a contributory cause, right? So by doing these different studies, by having this accumulation of evidence, we will transition from describing something as a risk factor to describing it as a contributory cause, where we actually are confident that it actually has a causal relationship with the disease. So that's a term that we'll use as we've started to build up enough strong evidence to say, yeah, we really do think that this is causing a health condition. All right, so let's talk a little bit about the first factor here, which is the idea of cause actually associating strongly with an effect. So this is done very often using what are called case control studies. And that the way that these studies work, essentially, here we're speaking about the right-hand side of the slide. On the top, you'll see cases, and on the bottom, you'll see controls. So cases are the group of people who have the disease that you're interested in, all right? Be it cancer, or be it cognitive impairment, potentially due to lead or some other thing like that. Controls will be a comparison group. So controls are people who aren't patients who don't have that condition. So the idea here for a case control study is you're going to compare those two groups to say, do we see some factor popping up more frequently among people who have the disease? So if you look at those two groups, say cancer patients, and you take histories and you ask them a whole bunch of questions about their history in terms of what they're exposed to, whether they're exposed to lead, to toxins of various sorts, whether they ate certain ways. You ask a lot of questions, right? And you ask that both of your cases and of your controls. And so we go over to the boxes on the left side, and we see on the bottom, none of the controls have been exposed to, say, a pesticide, for example. All right, so they're all symbolized as red. However, we see on the top that about 3 out of the 5 people who have that cancer have been exposed to this pesticide. All right, so you can do a statistical test to compare those two groups, and you can say, hey, it looks like, statistically speaking, people who have cancer are more likely to have been exposed to that toxin. And what this does is this shows at an individual level, because these individuals had been exposed to that pesticide, that there seems to be a relationship going on between an exposure and a disease outcome. Again, this is different than group associations because we're actually looking at individuals and showing that people who have exposures actually are more likely to have a disease. So there's a few reasons that we use case control studies a lot in public health. One of the main ones is that they're actually relatively cheap. So finding a group of people who have a disease and who don't, it's a pretty easy thing to do, a pretty cheap thing to do. It's also relatively quick to do it. Now, one thing, caution here is that you really want to make sure that you have a good control group. If you're comparing cases to controls and the controls look very different than than your cases, then things that you see as risk factors might actually not be something that you're interested in. It might be a confounding factor of various sorts. So, for example, if you're looking at cancer patients or people who are sick, they might be substantially different than people who are entirely healthy. People might be entirely healthy because they've been very careful generally about exercising more or doing a range of different things which might influence their health. And that makes it much harder to narrow down whether there's differences between sick groups and your controls. So always something to consider when we look at these case control studies. So let's look at the idea of cause preceding effect. So remember, if you think that something's causing a disease, you want to make sure that people are exposed to that causal factor, that toxin, that risk factor, before they actually develop that disease. And one of the best ways to do this is by doing what's called a cohort study. Now, cohort studies essentially identify a certain group of people, a population, that has a shared factors, and then they follow that population over time. So a very famous one of these is the Framingham study, where they recruited men and then a larger group of people, but initially started out with just men who lived in Framingham, Massachusetts, and they just followed them over 50 or more years and looked at how their health developed over that time. So when you have a certain cohort of people, you assume that they're roughly the same, and you follow them over time, and you watch what things they're exposed to or not, whether they smoke, whether they exercise, whether they do different things. And then you look to see who develops a disease or who doesn't develop a disease. And you can do a statistical comparison between people who are exposed or not and see who develops that disease or not, and say, look, well, it looks like in the Framingham study, people who have hypertension are more likely to develop cardiovascular disease. So their exposure or their risk factor there is hypertension in this case. But we also see things around different types of cholesterol, for example. That's an exposure that increases risk for cardiovascular disease. Now, something that's notable about this is you can do this as a prospective study, what I just described as a prospective study, where you identify a group of people and you follow them over time. And that in some ways is ideal because you can actually have a lot of control over the quality as you're following them over time and make sure that you're asking the right questions. But another possibility is that you can identify a group of people that have a shared background, and then you can look back towards their history, back through time, and that's called a retrospective study. So you identify the group of people that had a shared background, say everybody who was in first grade in Orangetown, New York, all right, in 1978. Okay, you find that group of people, and then you go to them now. In the 2000s, and you then say, okay, for this group of people, we're going to look back throughout time to see what they're exposed to over the previous 30 years or so. So this has a lot of benefits. It provides that time component. One of the real challenges to this, though, is that it's very expensive, and it requires a lot of work to follow people over many years. So gathering that data, gathering high quality data is really quite challenging to do. That being said, when it comes to public health considerations, very often cohort studies are the best data that we can get to actually demonstrate that there's a relationship between a risk factor and a disease. So let's go on to our third way of looking at risk factors, looking at contributing causes. So here's the question of whether changing the amount of the risk factor actually changes the amount of effect, or whether or not you get an effect in a factor. So this is very often called a randomized controlled trial or an experimental study. All right. And these scientific experiments are really seen as being the strongest evidence of a relationship between two different factors. Okay. So how you do this, and you find a certain group of people who you wanted to work with, You would collect some baseline information about them because you want to control for different types of confounding factors and know a lot about that group. And then you take that group of people and you randomize them to two different groups. All right. So you randomize them to actually get an intervention or to a control group where they don't get exposed to some risk factor. Okay. Now, you could imagine doing a study like this where you randomize different people to either smoke a pack of cigarettes a day or not smoke a pack of cigarettes a day. And then you watch them over time, and then you measure how many people develop lung cancer or don't develop lung cancer. So this is really helpful for being able to determine whether or not a risk factor actually causes a disease. Because you've randomized between the intervention group and the control group, those groups should be roughly, on average, the same, right? It should control for a lot of these confounding factors, okay? So there's a real virtue to doing it this way, and it's a very strong study type. But what's the problem with this when it comes to public health concerns? Well, if we think that smoking is something that's bad for you and your health, would you really want to experimentally design an experimental study where you tell a whole bunch of people in your intervention group that they have to smoke? Well, no, you wouldn't want to do something where you could actually harm your population, right? And that's the case for a lot of public health concerns, right? So if you think that there's actually a risk factor that's actually going to harm someone, it actually becomes unethical to do a study where you tell them to smoke or be exposed to a toxin or something like that, right? So even though this is a really strong experimental approach, it doesn't actually work very well in a lot of public health situations where we're trying to understand how a disease is caused. The other thing I would say about these experimental studies is that randomized controlled trials actually have relatively poor external validity, which means that in a real world context, they tend not to match up very well with how things work out in the real world, right? So in many cases, these cohort studies can provide better evidence of how things are actually happening in a natural context. The other thing about these studies is they're also really expensive. So they're hard to do, and they cost quite a bit to do this type of study. Now, I should have mentioned that there are things called natural experiments. So when it comes to the relationship between a risk factor and an outcome, sometimes you have natural experiments where people, because of a certain circumstance, say you had 2 classrooms and it just turned out that in one classroom people were exposed to lead, in another classroom they weren't, right? And they were randomly assorted to those two different classrooms. And later on we think, well, what might be the impact of lead? Well, that's called a natural experiment, where something happens in the natural world and you can look at it and say, hey, we can use this to study whether or not that cause, being there or not being there, influences a health outcome. All right. So that can be really valuable in public health circumstances. We're trying to understand how a disease is caused and whether altering that cause influences the effect. All right. So how do we measure these associations between a potential contributory cause and an effect? Well, cohort studies and randomized controlled trials usually measure this using what's called relative risk. So relative risk is essentially a statistical measure that looks to see how big of an effect is going on. So here, a score of 1 means that there's no effect going on. Whereas if you have a score under 1, that means that it's actually a decreased risk. So it could actually be protective from a disease. However, you see if you increase above 1, that if you get something like a relative risk of 2, that you have roughly twice the risk of the normal population there. So you can actually do this using randomized control trials and cohorts because you're looking at an overall population. Now, case control studies are a little different because you've actually selected cases and controls, and you don't have a group that you can look at how they develop things over time. So what you use for case controls and studies instead is you use an odds ratio. So an odds ratio functions similarly to relative risk, except it often is an overestimate of the actual risk factor for a disease, especially if you have a high prevalence disease. Okay. But that's something that you will also see, and that's abbreviated as OR. So if you're reading research papers and you're trying to understand what these risk factors are, as you're trying to understand a project or a question that you're interested in, these are very often the measures that you'll see to indicate whether or not something might be a contributing cause to a disease. All right. So the second question is, okay, if we see that there's some sort of risk, we have a relative risk of 2.5 or something like that. As you're reading, how would you tell whether or not that's something that is actually statistically significant, something that you actually care about and trust? Think about it this way. If I were to take two people in the classroom and one of them had a red shirt and one of them had a black shirt, right? Would I be surprised that one of them has a red shirt? Would I think that that is a significant finding that 50% of them do? Well, no, probably not. That's just kind of a normal thing. But if I then looked at the classroom and I saw that 50%, we have a classroom of 48 people, and 50% of people have a red shirt, right? But the rest of the people have all other colors of shirts. Well, that might be a situation where I might say, that seems to be more than a random sort of thing. I see enough people wearing red shirts that maybe that's their team colors and they're just wearing red shirts because it's their team colors. So maybe there's something going on here. Maybe it's something that's actually significant that's this color is indicating, right? So that's the idea here, that there's if you look at enough people, you have a big enough study, you can start to actually doing a statistical measure to say, yeah, we actually think that something's really going on here. It's not just random chance. Now, there's a few ways that you see this. Sometimes you see this in a confidence interval. So if you have an odds ratio of 2.3, you might say that we are 95% confident that the true number is between 1.9 and 3.0. Okay. So that's indicating that we think that we're pretty confident that the real number is in this range, right? Another way that you see this measured, and this is actually very common, is using what's called a p-value. So a p-value, it's a little more complicated than this, but a p-value essentially measures the likelihood that what we're seeing here, that this distribution is would be observed by chance alone, right? So commonly a cutoff for this would be a p-value of less than 0.05, which means that roughly there's a 95% chance that this isn't random, okay? So the likelihood here, a p-value of 0.05, indicates that there's about a 5% chance that this is just a random finding, okay? So if you actually look at a paper, if you saw that a p-value is 0.13, that would suggest that it is not statistically significant, right? Because it's above that value of 0.05. However, if you see a p-value that's 0.02, well, that's below 0.05, and that's suggesting that it might be that it is statistically significant. Okay. So this is just something that it's important for you to memorize, because as you're reading papers, it tells you what data to pay attention to and what not to pay attention to. All right. So there's a few things as you are reading and looking at this type of research that you want to pay attention to. Okay. So one is that there are risks for having potential confounding factors in these types of studies and looking at the relationship with a potential cause and a potential effect. Okay. The other thing that you want to consider is the potential for selection bias. So this means essentially that you want to make sure that the groups being compared, especially in case control studies, are as similar as possible, because if those two groups are different, and importantly different, well, then effects that you see or relationships that you see might not actually be related to the actual cause. It might be related to some other factor that's associated with those two different groups. There's also the potential for information group bias, which is the idea that you may obtain or get or influence information differently across two different groups. So if you do a randomized controlled trial and you ask people questions about how sick they are. And in one group, you actually get that information by bringing them into the clinic and doing diagnostic tests. Whereas with the control group, you call them up on the phone and just say, were you diagnosed with that thing? Well, you might see a huge difference, but that might just be because you gathered the information in a different way, right? So that's something to pay attention to in these types of studies. All right. So those are three different ways, three very strong ways of demonstrating that there's a relationship between a contributory cause and an effect. But sometimes you can't always do all components of those three elements, or maybe your data isn't as strong as you'd like it to be. Well, there's other ways that you can actually show that this might actually be something important. So again, as I mentioned earlier, the strength of the relationship. So for example, for lead, we're actually seeing pretty strong relationships between lead exposure and a range of different cognitive impacts for children. I'll show you shortly about dose response. We also see across countries that there's consistency there in terms of lead exposure. And we actually know a lot about how lead might actually influence cognitive function biologically. So in terms of the actual impact of lead, we've done a range of different studies where we've shown that there is associations with a range of different health impacts that are fairly serious. Now, for children, low levels of that lead can actually have real big impacts. And for children, it's looking like even any exposure to lead may actually have health impacts for children. And this is partially because they're particularly vulnerable as they're developing. So what we see is a serious nervous system damage, slow growth, and anemia can happen for children. For adults, you usually have to actually have a higher level of lead to have health impacts. But you can have nervous system impacts, hypertension, kidney function impacts, and it can actually affect your ability to reproduce. There's another thing that we think about in terms of lead, which is for pregnant women. So when you're pregnant, there's actually a release of substances from bones, a release of calcium, and as part of that process, you can actually release a fair amount of lead. So some women who have stored lead in their bones can actually have spikes in lead in their blood, and this can actually cause miscarriages or growth impacts on the fetus. So that's another thing that we think about and are concerned about in terms of these lead exposures. So focusing in here just on these relationships that I discussed before in terms of the impact of lead on various different functions. Well, what we see is that as you're exposed to lead, that these different health impacts increase. So for children, they did something where they took teeth of children after they'd come out. They crushed them up and then measured how much lead was in those teeth. And there was, I think, 6 different categories there. And you can see across these different groupings, it's probably a little hard to see the measures, but here they're measuring things like attention span, behavioral problems, depression, other things like those types of behavioral concerns. And what they're seeing is there's this relationship that as lead concentrations in the teeth go up, that these different health concerns go up for children. And this is one of the pivotal studies that really helped push our government to consider lead as being a really serious public health hazard. Another study looked at this, looking at cord blood for children. And again, you see when you look at a cognitive function scale that children who have low cord blood lead levels have much substantially better functioning than the children who have high levels of lead in their blood. So this type of evidence is strong evidence suggesting that there is a relationship, and that you can show that there's begin to show that there's a causal association between a risk factor and a disease. All right. So given that we are able to look at these causal relations, contributory causes, and we can begin to find which factors we believe are actually causing the disease, the question then is, how can you actually prevent those diseases from occurring? And when we try and do so, how effective are our efforts to prevent the disease? Well, again, using the P.E.R.I.E approach, we think about looking at the etiology. The etiology essentially means the causes, the way that a disease is formed, morbidity, mortality, time frame, all those different factors, the different contributing causes, right? Based upon that, we'll then make a recommendation, all right? And these recommendations can come in the form of a range of different things. Very often you have a large body of experts in the field who come together and study all the research that's been done in an area, and they rank it and they grade it based upon how confident they are that this risk factor actually causes a disease. And then they also provide their understanding of the ways that you actually would address this by changing the way that we behave or the types of exposures that people have. Then the next step would, of course, be to implement this and continue the evaluation process. So again, this is the idea of continual improvement in public health. So what about these interventions? So it's really important when we go forth and try and prevent a disease from occurring by addressing these contributing causes, that we actually do assessment of it to see how effective they are, right? So remember, if we put a lot of effort into these preventive interventions, we're spending money, we're spending time. And it's a real waste of resources if it's not an actual effective prevention effort. So it's really an ethical obligation to us as public health professionals to do studies to assess how effective different approaches are. And you want to see whether it's better than nothing, but you also want to compare it to other possible strategies for addressing this public health problem. So in terms of figuring out how effective an intervention is, well, you can use exactly the same strategies that you use to demonstrate causation. So a very common strategy, for example, is using a randomized controlled trial. Whereas you can't randomize people to smoke more, you can randomize people to a group to take a drug that potentially decreases their risk of depression, right? There's something where you're actually causing benefit, where you're increasing efficacy, where you might actually see that there's a decrease in the impact of a disease, right? So there, randomized control trials work really well for demonstrating efficacy. You can also look at that in cohort studies over time. Do people who do certain things seem to have a decrease in their risk for a disease, or take vitamins, or exercise, or do certain things? That indicates that they might actually benefit from that, right? So the same studies that we use to show that a cause is associated with effect are the studies that we show where an intervention is associated with decreasing that disease outcome. Essentially because here we're thinking about the intervention as being a cause of decreased disease, all right? So when we think about lead, there was increasing evidence that lead actually had an impact on health outcomes. So the EPA had been looking at this for a while. And again, for a very long time, GM and DuPont kind of swept a lot of these concerns under the rug. But the EPA was finding that there's increasing evidence that this was increasingly a serious problem. And they published a position statement saying, hey, we actually really need to take this seriously. And based upon that, they actually used a Clean Air Act to start regulating lead. And they did this by regulating, creating a mandate that cars could no longer be built that used leaded gasoline. So they had to begin being built to use unleaded gas in 1975. And then later on, they then banned lead in household paints. All right. So this is the policy approach to creating an intervention that decreased the impact here. Then in 1979, they started phasing out lead from gasoline. So increasingly, they were transitioning from lead to unleaded gasoline, which is what we use now. And by 1996, it was expected that all that you can no longer sell any leaded gasoline. Okay. So that was the intervention approach that was used at a policy level. Again, these were obligations. It was obligatory, mandated by law, but they also did use an approach that did give some possibility for people to not have to sell their car. So they phased out the leaded gasoline over a period of time. Now, what impacts did that have? Well, we see there's a few different things. So one, we see that there's a difference over time in terms of, in red, you're seeing the amount of blood level, the blood level that was legally allowed to have for lead in the blood. All right, in 1965, that was actually really high, about 60 micrograms per deciliter. Okay, they lowered that to down into the 30s, 20s, and 30s. And then by 1990, they lowered that threshold down to 10 micrograms per deciliter. Right. So we're seeing that these rules about allowed blood levels went down and down. Now, what's nice is as these policies and thresholds for what we see as being acceptable blood levels of lead go down, we also see in a population that there's a decrease in these blood levels. And over time, we still see that we have some small portion of the society who has blood levels of lead over that threshold. But we're doing much better. These interventions that we took, that I showed on the previous slide, actually have worked to decrease lead impacts. That being said, we still have real serious issues with lead in the United States. So one thing is that we find that our overall exposure to lead, because so much was produced for paint, so much was produced through leaded gasoline, that it just exists in our environment. So they estimate that we have about 300 to 500 times the normal background level of lead that we're exposed to generally, because it's just so much of it in our environment. Okay. They actually estimate that as a population, during for a substantial period of time, because the blood levels were so high, through the 50s and 60s, for example, that the entire IQ of our entire population dropped by about 1 point. Okay. We also are seeing that lead in pipes, a real catastrophe that happened in Flint, Michigan, where they decided to privatize the provision of water. And because of that, because the company that they hired to do this didn't have controls, they have water that essentially leached lead out of the pipes, and it entered the water. And it took a really long time for public health agencies to recognize that this was an actual problem. It kept on being poo-pooed. And the truth is that most people think that this really relates to discrimination. It was a poor community that was affected by this. It's a primarily African-American community that is affected by this. So this is a real example of serious problems. And if you look at the exposures in the population of Flint, Michigan, well, we find that 1 out of 6 houses had unacceptable levels of lead in their water. And if you look at lead and water comparing to other locations, that there's actually substantial increases in lead for this population. So a real serious problem. It had a lot of children had negative impacts from lead exposure. Adults also had lead exposures that were over the threshold. So a serious problem, and it has taken a really long time to deal with that problem. And it's a public health disaster. It's a real shame, and the government really should be ashamed of how they've handled that situation, and it's a continuing problem. So the other thing I would say, just generally speaking, when we're thinking about lead, in addition to the general persistence in the United States, is that other countries around the world actually still use leaded gasoline, actually still have leaded paint. So there are other countries, if we think about global health, that are actually still having serious problems with lead exposure. So it's definitely a continuing environmental health problem. All right. So this is epidemiology in a nutshell. Again, the ideas here are we're trying to understand, to look at health across a population to see, oh, is there a spike in a certain disease in a certain location? All right. Should we be concerned about that? Looking at mortality rates, looking at incidence of different diseases can be a really powerful tool in public health. And large components of public health practice, their main focus is on just monitoring health in populations to see whether or not we're having an outbreak, for example, in a certain region. Then secondly, we need to figure out, if we're having a problem, what's actually contributing causes to creating that problem? How is this actually occurring? So this can be a really complex, challenging thing to figure out. And there's a bunch of different strategies that we think about using to demonstrate that there's a relationship between a risk factor and a disease. And that can be incredibly powerful. And in truth, it's very hard to figure out how we can have an intervention to solve a problem. How can we do something to solve a health problem if we don't really know what's the causal factors, right? Again, think about the Black Death and how much trouble they had figuring out what causal factors were so that they could actually effectively prevent this disease from happening. And then finally, epidemiology provides us with a lot of tools for assessing our interventions to determine whether or not they're effective in actually improving public health and decreasing these health impacts. So that's what we do. This is the basic science of public health that we use to understand it. And it's essentially the basis of medical professions, public health, any sort of health practice that's trying to understand how a disease exists in the population. So thank you very much for listening, and take care.